So I'm here to talk about zirconia versus titanium implants, and you're definitely looking at something that's out of the mainstream. Right now in this country, probably only about less than half of 1% of all implants that are placed are zirconia. In Europe, the percentage is significantly higher. You're looking at almost 5%. So they're, as with most things in this field, are a little bit ahead of us. What happened to my, one of my slides got deleted. Oh well, who cares? So as holistic dentists, and you've probably already figured out that once you get into this field, as if dentistry wasn't hard enough, we face all kinds of unique challenges as holistic dentists, and I think that's especially true when it comes to tooth replacement. And even though things have gotten easier, a couple years ago we didn't have all of the options like the Valplast and the thermoplastic partials and the zirconia, so it was definitely a little bit more challenging. We still face a lot of hurdles with patients who just don't tolerate some of these or just don't want some of these procedures. Like, you're not going to do a zirconia bridge if there's perfectly good abutment teeth. So this is like something you run across all the time, maybe a lone root canal tooth, and so we as holistic dentists that already has a strike against it. But most conventional dentists, they would maybe look at that and go, well, there's maybe a little lesion. Well, it's not completely filled. We'll just send it to the endodontist, and they'll make a halfway decent abutment. So, and with the technology that we also have available to us, this is actually what that tooth ended up looking like. So there was no way that tooth was ever going to respond to any type of endodontic procedure, and so now we're looking at really the only option either being an implant or doing a partial. And a lot of patients, some of them do well with those, but a lot of them really just don't want to wear a removable prosthesis. So that's what I want to talk about, is like what's the difference between the two materials, the pros and cons. Just out of curiosity, how many dentists here are placing implants right now? So quite a few. Now, are any of you placing zirconia already at this time? Okay. So I'll kind of start with, titanium and zirconium are right next to each other on the periodic table, and they're actually, if you look it up, they're actually considered very reactive type of metals. And what happens is there's actually an oxide layer that forms over the titanium that protects it from that reactivity. And that is also actually, that oxide layer is also what creates the process of integration and how the implant integrates. And according to them, it says it completely masks the reactivity. Well, that's really kind of the source of a lot of research right now. Does that really happen? Where does peri-implantitis come from? Where do some of the reactions to titanium implants come from? And so, of course, titanium, it's a metal. It has all of the properties of metals. It conducts electricity, temperature. It oxidizes, which is actually a good thing. But it's definitely not biocompatible. It's probably could be considered biotolerant at best, but I think what makes it biocompatible is really that oxide layer that does coat and protect it from the tissues. And then the other thing that's not talked a lot about in dentistry or medicine with these titanium metals are the impurities. In fact, there can be up to 2% other compounds elements in titanium, and they don't have to be listed as part of the product. So less than 2%, it's considered an impurity, and they can still call it 100% titanium. So there was actually a German study done, and they kind of looked at the impurities in these titanium metals that were used in surgeries, and what they found was actually pretty shocking. They found that there were all these different, there were all these different impurities that were detected, like aluminum, chromium, nickel, palladium. And I thought this was really interesting, was the fact that, that there's enough of these elements, of these impurities, that if you have an allergic reaction to that particular metal, it's enough to elicit a response. So if one of your patients has a nickel allergy and you put in a titanium implant, you think, well, you know, it's titanium, we're okay with this. In fact, there could be enough nickel in that implant to elicit a response. And I think obviously different companies have different, I guess, requirements for how stringent they are as far as the purity. That's why, you know, I think when I did place the titanium at one point, you know, you're looking for the good, high quality Swiss implants, and it's kind of the same thing with some of the other metals. In fact, it was kind of interesting. I was talking with when I first got, I was just doing my training. It's kind of I guess a little bit of a personal story. My father very suddenly passed away from acute myelogenous leukemia, and he had a couple hip replacements done about 10 years earlier. And as soon as he had these hip replacements done, just noticed he started getting all these purple splotches on his arm. He started getting psoriasis, just really weird reactions. We always were a very healthy family, no cancer in the family, so this was kind of a surprise. And I was doing my training for the zirconia implants, and the president of the implant company from Switzerland was there. And we're just talking, and he happened to mention, you know, in Switzerland, we don't just make the dental implants, we actually also make knee prostheses, we make hip prostheses. And he says the nice thing is the insurance companies actually have a higher rate of reimbursement for the zirconia than they do for the titanium. I was like, well, that's kind of unusual. I mean, you know, insurance companies, they're going to pay for, you know, if there was amalgam, you know, hip replacements, they'd pay for those. So I said, you know, why is that? He said, well, they wear less. I go, what do you mean wear less? It's titanium. They make like airplane wings out of these things. And here we're talking about little hips, like how much can it possibly wear? Well, he said, no. He says, as soon as you put titanium in the body, it starts to corrode, and we can see, number one, titanium particles in the bloodstream, and we can see changes in the white blood cells. And it was like I was just kind of like the lights went on and go, holy cow, you know, it just make you wonder. Now there was a 10-year delay, and who's ever going to make that correlation between putting in hip implants and possibly getting a type of blood cancer 10 years later? But, you know, I thought that was just very interesting. And so this is Dr. Davidas. He is considered the most, I guess, the one who's done implants the longest. He's been doing implants for over 60 years. And he talks about it, and he's done a lot of research, and he talks exactly about all of the problems that we're talking about here, that they do corrode. And I'll actually talk to you in just a second about the difference between corrosion and oxidation, because there's actually an important difference there. But they do release metal ions into the body. They create immunotoxicology and systemic disease, including cancer. And even way back when this interview was done, he was talking about the need for titanium alternative. Well, the good news, we do have that, but you know, getting back to that dense oxide layer, that really is what protects the implant from all of the things that can create the problems and the release of those metal ions into the body. So when you look at mechanical stress, when you look at different acids in the body, different even where there are contact points, what ends up happening is you end up disrupting that layer, and one of two processes end up happening. And there's actually a new term that I hadn't even been familiar with called repassivation. Passivation. I don't know, it's a hard word to pronounce when you haven't seen it before. But essentially, the question was, when you disrupt that dense oxide layer that's protecting the implant, does that layer reform and continue to protect the implant? And the research seems to be showing that that in a lot of cases doesn't happen. And once you have that non-oxidized implant exposed to oral tissues and the bone, the implant basically starts to corrode. I mean, it's basically, you've got an implant that's literally rusting in the bone. And that's what they're finding now with peri-implantitis, is a lot of these titanium and metal ions are found in the surrounding tissue, and it creates a whole acidic environment, and it's coming from implants that have lost that protective layer. So it's kind of interesting. They're doing, they're doing more studies about whether that happens, because in the past that was just kind of assumed that, hey, you disrupt the layer, it's just going to reform. But now the research seems to be showing that that doesn't always happen. And so I put a whole bunch of, I updated the slides from, I just uploaded the latest ones, and some of these studies, if you downloaded the PDF from earlier, those may not be on there, but there's actually some really interesting studies that have been done. And I don't want to spend too much time kind of bashing the titanium. I think there's, they've obviously have had a long history of success. I think we just have to be aware that there can be some issues, there can be some problems, and then I just want to show you that the alternatives that we have today are pretty much, as far as what, from our experience, superior in every way. So it shouldn't really even be an issue as to whether or not we even think about doing titanium implants anymore. So I put a number of these studies in, and you can, if you download the slides, you can look at those. There's a lot of, Dr. Katsakis has some really great papers, but you can look at what's happening with titanium. So I really want to just kind of move on to the good stuff, the zirconia implants. And I think I just hit a button. Here we go. And I put up zirconia. Zirconium is a metal, but zirconia is not. And the reason I put that slide up there, because even now, every once in a while, I have discussions with people who insist that the implants we're doing are metallic. And I'm trying to explain to them that there's a difference between zirconia and zirconium. So zirconia is a completely different animal. It obviously acts as an insulator. It has limited thermal conductivity. It's non-oxidizing because essentially the whole implant is oxidized and specifically designed to be that way. And it's tissue and bone friendly. And I'll show you some slides later of some of the things that it's capable of doing that you could never get away with if you were trying that with a titanium implant. So the zirconia has been really nice because when you're using it, it's much more forgiving, especially in the aesthetic zone. When you have that white material, especially in thin tissue types, you don't have to worry about any of that, the gray showing through. And now currently the surgical techniques have gotten much more like what we're used to with the titanium. Because initially with the one piece, it was most of those systems, and there still aren't a lot of fully guided zirconia systems. But they do have partially guided systems that are very effective, that let you get the implant right where you need to. And now we also have some better two-piece systems. Some of the initial two-piece systems were cementable, and there were just a lot of issues with the connectors breaking, and all you need is a couple of those to break, and spend a couple hours trying to dig out some little thing, and you're like, I'm not using this again. So that's improved tremendously. So these are really probably what I consider the top 3 systems in use right now, and these are the ones that you'll probably see the most here at when you go talk to the exhibitors. They're usually the ones that are here. I started with the one piece, and then they have one with a little more aggressive thread. This is the one that I think turned out to be a little problematic. They've changed the design of that significantly. And the nice thing about the Xeramex system is they actually produce the implants for Nobel. So that is the same as the Nobel Pearl. So the if you're designing or even some of the surgical kits, you can use there's some crossover on that. And they just came out with an even smaller 3.5 millimeter implant for anteriors. Those are the systems that I just have experience with. I've looked at the system a lot. I think it's an amazing system. I think that the problem is once you commit and have all of the supplies and the surgical kits and all the little parts that you need for when you're doing implants, it's really hard to just switch course and start over. But I really like that system, and they're very. If you've looked at if you've been to meeting, I don't know. Well, you'll see when you go to their booth here. They're out of Switzerland. They're very health oriented. They have kind of almost like a whole program for helping people and helping the doctors succeed with the system. The couple doctors I've talked to also like how these are restored. They find that the restorative part of the Swiss dental system works really well. I also really like the Straumann. I've used a number of these. They're called the Pure implant. I was really excited when they first were talking about coming up with a two-piece system. And I remember going up to their booth at the Chicago Midwinter meeting, and I'm looking at the implant. I said, "Well, this has metal in it." And they said, "Yeah, but the metal's on the inside. It's not in contact with the tissue." And I said, "I'm a holistic dentist." I said, "I don't think you understand our patients." I go, if they're going to make the investment to get an all zirconia implant, they don't want any metal in there at all. Interestingly enough, that Z system was actually originally developed for the Paracelsus Clinic in Switzerland. And Dr. Thomas Rao, who's the medical director there, actually he didn't just want a metal-free implant. The entire surgical kit is made out of zirconia. The scalpel, the tweezers in there, every burr, there's not one piece of metal in that entire surgical kit. So yeah, when I looked at that implant that had the metal sleeve inside, I said, well, it's nice, and I'm sure for a lot of people it would work, but obviously for our patient pool, they wouldn't want to have anything in there that's that's metallic. And then the other thing about the Straumann Pure is that you can't prep these at all. So it's a wonderful system. It works beautifully, but you really have to make sure you get your implant exactly where you want it. With the Z system, you could actually prep those if you had a 50 micron diamond and use plenty of water, you were just fine you could even change the margins, you could change the angulation, and it was pretty forgiving. And when I first started placing these, they said, well, don't touch them with a diamond. I said, well, you can use a 50 micron with a little water. No, you can't touch these with a diamond. It's going to create microfractures and potentially break. So it has to do with the way the zirconia is processed. And a couple of the companies use this high-intensity pressure process that I think it's actually 3 days under this high pressure, and it just eliminates these voids. So it's better at preventing the microfractures, and that's really what allows us to go in there and use a burr if we do need to make some adjustments. And really, there is a significant increase in the strength when you do that as well. So I like, obviously we're already worried about how strong these things are, and that's always a question. We'll talk about that in just a little bit as well. But really, the cool thing was the different systems. Now, when I first started, I used the one piece, and it's about as simple as it gets. You really don't even think you're doing implants, because once you put the implant in, it's like you have a prepped tooth. There's no transfer copings, there's no closed open tray impressions, there's no implant analogs. I mean, when you do implants, you've got all your little utility boxes filled with a million little parts. And so they were very easy to place, and there really weren't any parts, and there's also no interface. So once it's in there, you don't have to worry about any place where there's any potential for just a weak point where bacteria can get in or problems like that. You know, on the downside, they definitely weren't as versatile. And once you place that implant, it's like putting an implant on and putting your abutment on. You couldn't cover this implant up and let it heal. You already had the basically that, you know, this part sticking out. So that was always the biggest challenge, was how do we protect that during healing, because it's during swallowing, chewing, just that micro movement was disruptive to the integration process. And I think that's why initially the success rate of the zirconia implants was lower than titanium, because we were dealing with trying to protect these implants during that integration process. Because as far as the material and the integration, once now we pretty much know that zirconia integrates every bit as good or better than titanium. So it was nice when this happens to be the Z systems. They use a carbon fiber screw that's very strong, and it pretty much acts just like you're placing a Nobel implant. It's relatively easy to place, very versatile. They have angled abutments, but it's got all of the workflow. You can put a healing cap on there and cover it. You can put, if you wanted to, you could put temporary crowns on there, but it's much more. If you're coming from a world of placing titanium implants, this is going to be really nice, because it's going to have the same feel as what you're used to. Fortunately, I haven't had any problems. I know some people have had maybe some issues with, anytime that there's an interface, there's going to be some issues. But for the most part, I've found that to work very well. The only problem is once you put the screw in, it's actually a really interesting process. The threads are really pointy, but the screw looks like it has rounded corners. And when you put it in there, you're only torquing it to maybe 15 Newton centimeters, but the threads actually adapt into the threads of the implant. The only problem is if you back that screw out, it's a one-time use. So if you back the screw out, you buy another $85 screw. That tiny little screw is $85, and so you end up having to start over. But for the most part, it's a great system, and pretty much all of the other implant two-piece systems have something similar. Not the carbon fiber. I think some of them are using zirconia screws as well. So there's the question, how strong are they? I actually updated the slide because this is an older slide. The flexural and tensile strengths of the new zirconia implants are actually equal to the titanium, and compressive strength is significantly higher. Here's some numbers on that. So if you look at tensile strength, very similar between zirconia and titanium. Compressive strength about twice as high, and then modulus of elasticity is higher as well. So people are worried about. I think you just inherently are concerned about ceramics and these types of materials breaking, but that really isn't the case. And then all of the times that we've done these implants, we have not had an issue with any implants breaking. So I never really am concerned about the strength part of it. And I'll even show you, I'm showing my case on how an implant did not get put in properly, and how even with as poorly as it was placed, it's still functioning just fine. So really, success depends on good planning. And as holistic dentists, we're kind of why people. We always want to know, why things are happening. And so for when you're placing implants, it's really important to know why the teeth were lost in the first place. So if it's somebody who maybe had some bad habits or bad luck, like an accident years ago and they lost a tooth, that's one thing. But are they in poor health? We're looking at airway a lot more. A lot of the clenching and grinding is due to airway issues. So Case selection, health history, smoking, history of bisphosphonates. Those are always the top things that we look at. And then really the clenching and grinding is something that we're looking at more now. I've kind of put more of the focus of my practice on airway, so I'm learning more and more about just what types of forces people can put on their teeth at night. I was at a recent conference and they had a device called GemPro, and they gave a couple of these home for some of the doctors, and you put it in at night. It measures the maximum biting force, and one of the things you do right before you go to bed is you bite down as hard as you can on the sensor. The next morning, some of the readings that these dentists had were 3 to 4 times what their maximum. I mean, think about that. Think about clenching your teeth together as hard as you can, and at night you're biting 4 times as hard. I looked at those readings. I said, well, no, because sometimes you look at things, you go, how the heck did you break this? Well, when you look at the readings of the biting forces that we're able to generate at night, you go, well, okay, that makes sense that you could break a zirconia bridge with that type of force. So it's really interesting. So that's something that you have to pay attention to. You don't want to put zirconia implants in when people have those issues. And there are definitely some signs, that we're looking for now: the clenching, the wear, perio issues, scalp, tongue, mouth breathing. Those are all things that you want to make sure you address before you start placing the implants. Of course, we want. I'm sure everybody that would be placing implants at this point, 3D cone beam is obviously the standard of care, and we're not just looking at the bone mass and the bone density, but also looking at if there were previous root canals. I think that you just have to be upfront with patients, but we definitely find that areas that we're placing implants in that had previously had root canals tend to have a potentially higher failure rate. Case selection, one of the things is that, again, avoid, especially with root canal teeth, and I'm talking about just immediate, because the immediate placement, we started sending, we've had a few of these. Actually, my oral surgeon now places zirconia implants, and it seems like oral surgeons, when they pull a tooth out, they just want to, they're like, we're in there, we got the patient under, we want to get that implant in there. And the failure rate it's probably more than 50%. And even, we had a case the other day, the patient just snapped off a tooth. It wasn't even infected. We're like, okay, this doesn't look so bad. Let's go ahead and put an implant in, and it ended up failing. And I think you just have to look at, sometimes we don't realize how the blood supply can be potentially compromised in those areas. So now we tend to just say, all right, let's do the extraction, let's get some PRF in there, let's let it heal up for a couple months, and then place the implant. And when we go that route, it's very, very rare that we have an implant that doesn't integrate. This is a little bit easier, and I talked about the PRF, and we use lasers. A lot of our patients are already very open to the idea of taking supplementation. We like to irrigate the areas with ozonated saline. That seems to be really beneficial for helping with the integration as well. And then the rest of it is really just good mechanics, making sure that you place the implant in the proper position, and have all of the things that we look for when we're doing conventional implants. The nice thing is now most laboratories, if you give them a cone beam X-ray and a scan or an impression, they're going to be really good at designing you a surgical guide to place that implant. And what they're doing now, this video is actually This video here is of the first implant that I placed, this is probably like 2011, and I was using, at that time, I got the cone beam really because I couldn't get any of the surgeons in my area to place the zirconia implants. They just kind of looked at me like I was crazy. So I'm like, all right, I guess I got to do this myself. And I was already a CEREC guy, so I said, all right, let me get the cone beam, and I'd seen some of the things that were possible. The process is actually pretty simple, and always like the fact that you could reverse engineer the whole process. You could start with the end result in mind, and then put the implant based on where the restoration was going to go. Because there's nothing worse, and you've all had that. You've gotten an implant back from a specialist, and you look at it and you go, well, how am I supposed to restore this tooth? And you can't say anything bad about the specialist, and if you try to restore it, it's not going to turn out well. So you're kind of in a tough spot. So this lets you, and the process is still, even though this video is that old, the process is still almost identical. But what it actually allows you to do is take an optical scan and correlate that to your cone beam scan. So you give it a couple reference points, and then it literally puts that optical impression right into the scan. The nice thing is you see exactly where the tissue is, you see exactly where your restoration is. Then you go into your implant library. So this is if you have this kind of technology, if you're a geek like me, and Michael's a geek, we like our technology, right? So it's still nice to be able to do some of these things yourself, but what it allows you to do is place that implant not just where the bone is, but you're also looking at it in terms of where does it need to be for the final restoration. And then once you plan it on there, you basically, back in that day, you had to send it to, we actually sent it to Germany. It was this long drawn out process. Now, of course, we can mill them in our office or 3D print them, and we have all kinds of other options. But that was actually post-surgical right at the time. I never did a lot of, I picked my cases very carefully. I did most of my cases using tissue punch, and then I had an oral surgeon that I worked with that used to come in and place the more difficult ones. But a lot of I mean, for most cases that's really all you need. But that's what it looked like right after surgery, and that was when the case was all done. And you can see, even if you see a little bit of that implant exposed, you still don't have to worry about that there's going to be a problem with the aesthetics. So that's the key. And going back to when you're looking at the strength of these implants, you want to load these things in a compressive manner. And obviously with implants, we're already paying attention to make sure there's no lateral and excursive interferences. But I could have very easily placed that implant at an angle, but there was enough bone there to place it in perfect alignment with the long axis of the restoration. And that's what we're looking for to minimize the stress on that tooth. So what happens if what happens if you mess up? I mean, those things do happen when we're placing implants. So a couple cases. This actually is my mouth. I went to an oral surgeon. I made him a nice surgical guide, but he's an oral surgeon, so he doesn't need surgical guides. And he said, well, I'm just going to flap it, and we're going to put these implants in, and it's going to be just fine. Well, after the surgery was done, took a pano. It looked absolutely beautiful. And this was actually right before I moved from Wisconsin down here to Arizona. And it took a long time to heal. And I just thought, boy, it just doesn't seem right. And I got down here, I had a cone beam x-ray taken. And lo and behold, that implant, if I put my finger right here, I can feel that spot right here. I can feel the threads on the outside of that implant. Now, I'm thinking if that was a titanium implant, I would probably be having that removed. And I don't think you would get this kind of tissue tolerance where it's never sore, it's never irritated. So I think it's very forgiving. Now, the other thing is, look at I've been a lifelong grinder. My bottom canines look like a mirror. And you can see how flat they're ground here. Look at the angle of the implant and then the way they had to put that crown on, I wasn't as much concerned about the implant failing as this crown getting knocked off. But this has been in here now, I think, 7 years, and haven't had any issues with it. Certainly taking that implant out would not be, I mean, you'd be destroying a lot of bone and creating more problems. So I'm very thankful that I had the titanium put in there. These were all my dental school disasters. When you let friends work on you in dental school, seemed like a good idea at the time when you're trying to graduate, but I ended up with a bunch of root canals and bridges, and so now I'm working on getting all those out and replacing them with the titanium with the zirconia implants. This was another case. The implant was placed really poorly. The patient came to the office. Not only did it have poor angulation, it also wasn't placed deep enough. You can see the threads are exposed. The patient had spent about, I want to say they spent about $6,500 for that implant and that crown, and this is what it looked like. This is from the lingual. It didn't look much better from the facial, and she was getting food stuck in there. It was not a good situation. Actually, she was contemplating going back to the surgeon and having the implant removed. What we ended up doing is we actually ended up taking a smaller abutment. This was a 4.2 millimeter implant. We actually ended up taking a smaller abutment and prepping it, and then we used the actual implant to create the margin. And so I shaved a little bit off the side of the tooth, but this is the final result that we ended up getting. And now I didn't get. She ended up moving back east, so I didn't get. But the papilla were actually starting to fill in. Here's another. And she was obviously happy that she didn't have to go through the whole process of, taking out any implant is not a lot of fun, and these zirconia ones are probably even trickier. Here's another case. Nothing was done. This is literally just the tissue creep of the tissue just literally growing up on the implant. So these materials, the tissue and the bone responds completely differently to the zirconia implants than it does to the titanium. So the final key to success, I think you really can't go wrong with any of the systems. It's really, when you come here, it's a great opportunity to go around and meet all of the different companies, talk to them, and then really just find out what system that you like and feel comfortable with. And all of them have great educational courses to make you successful. And the cool thing is our patients really want this service. It's remember Richard Dawson? Survey says almost 88% of patients say that they would prefer a white implant. So even though they're just thinking in terms of aesthetics, I think we're giving them a much better product. And ultimately, I would say that ceramic implants aren't just the best choice for the practice. They're just for a holistic practice. I think they're just the best choice in general. So hopefully that obviously this isn't going to teach you much about doing the implants, but I really wanted to hopefully get you thinking that the zirconia is a really good viable option to titanium, and that you can deal with it in a way that you're already used to if you're doing implants. So that's it. Thank you.